Welcome to Jewish Midlife. I'm your host, Devora Krasnianski, and today we're delving into an area that's absolutely crucial for our overall well-being, pelvic health. As we age, maintaining our pelvic health becomes more and more important. Our pelvic region plays a vital role in supporting various bodily functions, including our bladder and bowel control, stability, and even blood flow. That's why I'm excited to share this episode with you. I spoke with Dr. Millie Schweky, a doctor of physical therapy from Israel, who shared invaluable insights into pelvic health for midlife and beyond. Dr. Schweky offered practical tips and exercises that anyone can incorporate into their daily routine to strengthen this vital area. We covered a range of topics, including bladder control, constipation, vaginal dryness, stability, blood flow, and much more. It's never too early or too late to start prioritizing pelvic health. Join us as we dive into the world of pelvic health with Dr. Millie Schweky. Let's get started. Millie, I'm so excited to be talking to you about this important area of pelvic floor for midlife. I know we talk about it a lot for pregnancy, but it also follows us into midlife. So before we even start talking about this important topic, could you tell us a little about the work that you do?
Yes, first of all, thank you for having me. I've never done an interview about midlife, and it happens to be that I treated a lot of this population in my first job out of PT school. So I'm very happy to share today. So my name is Millie Schweky. I'm a doctor of physical therapy. I went to Brooklyn College for undergrad, Touro of Manhattan for my doctorate. I first practiced in Brooklyn, New York at an amazing clinic called Forward PT. I then moved on to open my own clinic, and then I moved to Israel. So now I'm currently practicing in Ra'anana. I call my clinic Kavana Physio, because our philosophy is that we are in control of our bodies, and we can actually use our intentions to turn on and off different muscles and pathways in the body to help with our healing. I treat women throughout the lifespan, so I think I'm most known for my pregnancy and postpartum, but I have a good amount of experience treating women in the menopausal and perimenopausal stages of life. So I'm very happy to be talking about this today.
Wonderful. I'm really intrigued with what you said about the Kavanah, so I hope that we weave that into our conversation. So,
Sure.
but before we even get started, let's just identify what are we talking about when we talk about pelvic floor?
Sure. Okay, so the pelvic floor is a group of muscles located between our hips. I actually don't like to call it a floor. It's more of a diaphragm. The way it works is that there's a group of muscles, and just like your shoulders have a left and a right, these muscles have a left and a right. There's three main layers, and inside of these layers are our organs for females. It's the bladder, the uterus, and the rectum in the back. The muscles run from the pubic bone back to the tailbone, and then from one side of the hips to the other side. These muscles have five main functions. Those are sphincteric control, so they hold our bowel and bladders in all day, and they release appropriately when we have to go to the bathroom. The second function is stability. So if you ever hear of having a strong core, the pelvic floor muscles are part of your core muscles. Then it has support. So it actually supports the bladder, uterus, and rectum that we mentioned, and it helps keep them in place along with a lot of fascia and other ligaments and other connective tissue. Then, of course, there's sexual function. A sexual experience is going to differ depending on the tone of your pelvic floor muscles. And then the last one that no one really knows is actually blood flow. The same way you do ankle pumps on an airplane to bring blood back up to your heart, your pelvic floor actually helps pump blood back to the circulatory system.
And all of those start changing a little bit. I mean, throughout life, but especially at perimenopause, menopause. So let's pick one. Let's talk about bladder control.
Sure. Okay, so I actually had a patient come in this morning with pretty severe incontinence. She wears a pad most of the day. It was her first appointment today, and I was like, oh, for sure, prolapse. She's 69 years old. Her balance is not that good. I could see her like waddling in through the door. I have a feeling this is going to be prolapse, and she already had reached out to someone and getting a pessary, and I was like, okay.
Well, identify prolapse and pessary.
Yeah, but there was no prolapse, actually. I did find a good amount of pelvic floor weakness and some vaginal dryness. which also didn't shock me, but I was expecting that there would be a bladder prolapse. I did find some ligamentous laxity around the bladder, but it was in place. So whatever, she needs help with coordination. So I could get into a little bit. This is a really good example to use to, kind of educate your audience about urinary incontinence and bladder issues. So on one hand, I see a lot of discoordination. So if you think about the trunk, and I mentioned before, the pelvic floor is, I like to call it a diaphragm because it moves. So every time we take a breath in through our nose, our air should fill our abdomen 360 degrees, meaning air should go into our back, our rib cage, and our abdomen. So front to back, side to side. Air also will put pressure down onto the pelvic floor. So when you inhale through your nose, pelvic floor should relax. And when you exhale, pelvic floor should contract. Many of my patients, especially the one that I saw this morning, will tell me like, wait, doesn't it work the opposite? Because we're so used to being in a paradoxical breathing pattern from being, constantly stressed and busy all day that we don't ever truly take a deep breath most of the time unless we're instructed to do otherwise. And a lot of what I see with this patient population is pelvic floor discoordination, meaning when I ask them to cough, I'll see their pelvic floor bear down, which would let urine out, right? As opposed to contracting to keep everything in. So that's just one piece of the puzzle. Of course, there's also posture. So our posture does change over the years as our bone density changes and we start to lose muscle. It starts as early as the age of 35 years old, which is shocking, but there are things we can do to help strengthen and bring better alignment and balance to the system. We could work on habits. This is a really huge thing. I'll just use my little metaphor. When you brush your teeth, first you floss and you get like all the gunk out between your teeth, and then you brush and you get everything else out. This is how I kind of do my bladder training before I even like touch my patient. I like to start them on a bladder training program if it's obvious that they need one, which means we just clean up their habits. We just floss away like the things that are in between and get those out of the way. And then we see what's left, right? So if I have a patient that tells me they go to the bathroom every hour or even every 45 minutes, and sometimes they don't make it to the bathroom and they wake up in the middle of the night more than 2 to 3 times, which it's normal to wake up one time above the age of 65 or during pregnancy, but it's not normal to get up 2, 3, 4, 10 times, which I've had that before in my office. So we could use different bladder training techniques to space out how you're going to the bathroom, to make sure you're emptying every time you go, to make sure you're not sending false messages to your brain to tell your bladder to empty. And then of course, lifestyle like diet and exercise can also help decrease the amount of irritation that's in the bladder, causing that urge to go.
So I do want to define what prolapse is, but I want in a minute. But let's talk about what is one of those bladder control training techniques.
Sure. So the way I actually start is I have my patients keep a bladder log. And so it's a really annoying chart. People usually don't like me when I give it to them. It's like 3 days of your life, sometimes 4, where I have you write down everything you ate, including how much water, how much coffee, tea, basically anything you consumed, how often you went to the bathroom, how many seconds the urine came out for, how urgent was it? Like, did you go just in case, or were you like running there, or was it somewhere in between? Were you leaking? And if so, what was your activity with leakage? This is a whole chart that I give my patients, print it out, fill it out. I'm usually able to decipher it and come out with different techniques based off of what I'm finding, because I'm usually be able to see a pattern over a few days, and then we could take it from there. So some of the techniques that we use are something called double voiding, which is basically when a patient gives me symptoms that indicate that they may not be fully emptying their bladder, such as standing up from the toilet and then feeling like, oh my God, I have to go again, even though I just went, like there's a little bit more. So when someone has something along those lines, I would recommend you go to the bathroom, you finish what you're doing, You lean forward. That tips the pelvis and the bladder to maybe get more urine that might be hiding out. You could stand up, shake it out a little bit, sit back down. Pretend you're going again from the beginning. You'd be shocked that you might get another small stream of urine. Sometimes it's just a few drops, but if your bladder is already irritated, those few drops could feel like a full bladder and give you the, the urge to have to go. So that's one technique.
Easy enough. Just have to know about it.
Yeah, pretty easy. Some habits that are easy to implement are to not go just in case you leave the house.
Say that again. Don't go just in case. That's very tricky.
Yeah,
You have
don't
an
go
hour
just in
drive.
case. Mm-hmm.
It's like,
So there are
also
exceptions
plan
to the
when you
rule.
drink so that you can.
Yeah.
Okay.
So those are two good points. One is that there are exceptions to the rules. So if you're going to be in the car for more than 2 hours, then that's okay. Because we should be able to hold our urine between 3 and 4 hours. So if you know the car ride is going to be more than 2 hours, before going to sleep, or obviously after you have sex, to decrease the risk of a UTI. Those are the just in case exceptions. And you're saying about drinking water, the best way to drink water, I should do a tutorial on drinking water. It's like this. Instead of sitting there, chug, 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 because you're so
just for those who are
thirsty.
just listening to it, she just sipped some, didn't just.
Yeah. Just sip, one sip, nurse it. Don't sit there and be like, oh my God, it's 3 o'clock and I didn't meet my water goal. I'm supposed to be drinking more water. Let me just chug the water. If you already have symptoms, then it's not really going to help you because your body's not going to have time to absorb all that fluid. So you're just going to filter it out through the kidneys more, and you're going to have to go more. If you drink it slowly, your body is actually going to get that hydration a bit better, and you won't have to go to the bathroom all of a sudden and it's urgent.
So it's like sip throughout the day. So just have your water bottles, your cups throughout the day, meetings, even traveling. Just don't go right before and don't go right when you get to your destination so that you're going to pee it out as soon as you get there.
Yeah, exactly. And that's another thing, because you said right when you get to your destination. I just did a post about this the other day and it got a good amount of, I think it resonated with a lot of people, about, I call it key and door syndrome. Like when you get to your house or even pull into your driveway and you're like, oh, gotta go, and you have to run. So the first thing you could do to help yourself with that is just slow down, take a few deep breaths, do a few pelvic floor contractions that kind of tricks your brain into telling your bladder to shut off. And buy yourself some time. Maybe it'll only be 30 seconds, but slowly and slowly you could really build yourself up. As easy as it is to train your bladder into having poor habits, it's actually equally as easy to train your bladder into having good habits, because it's a really habitual organ.
So I'm just thinking that it may be hard to train, but the benefits is so worth it. So that even though it's hard
worth it.
to remember, like that log, I mean, it sounds like a pain, but just
Yeah.
knowing on the other side, just doing that exercise, and then on the other side, you'll have some better bowel control. It's just wow, it sounds like it's a little discomfort now for a lot more convenience and ease and comfort later.
Yeah, and the turnaround time on the bladder training, in my experience, has been insanely quick. I've had people within 2 weeks tell me that their symptoms got significantly better. And this is with very basic exercise. And then with whatever symptoms are left, I hit them hard with the exercise and the self-work and the things you could do on your own to help yourself.
So it's not only exercise like Kegels. There's much more when you say pelvic
Way more.
contractions.
Way more than that. I think PTs are really, we have really bad PR. For some reason, everyone's like, oh, you're a PT. I do my Kegels. And I'm like, cool, I barely prescribe Kegels. The pelvic floor is a part of your body, just like anything else. Just like I said before, just like your shoulders, right? So if you think about it, someone gets a shoulder injury and they have to throw a baseball. We're also going to be working on their spinal rotation. We're also going to be working on their lats, on their, their back, their neck, right? We're going to be working on everything in the area. So I'll just give an example. I had a patient who I'm about to discharge. She's doing so well. I only started seeing her maybe 6 weeks ago. No, less. I think 5 weeks ago. And she was leaking basically like throughout the day. She had to change her underwear all the time. We did the classic bladder training, 2 weeks. We got rid of like, I think more than 50% of her symptoms. And then we were left with the other 50 for the bladder training to, catch up to, and then, to actually strengthen her. Her main complaint was that she would leak while she was walking somewhere. So a lot of our exercises included single leg movements, because when you're walking, you're picking up one leg at a time, you're rotating your torso the opposite way. So my job is to break down her specific gait pattern, how she walks, how does she land? She land on her heel, on her midfoot, does she stomp, how do her hips move, right? And then I have to be creative and come up with exercises that would optimize the way that she walks with the pelvic floor and the core and her breath and everything in mind, so that by the time she's done working through her exercise program, she could just go for a walk and she doesn't have to think about it. Oh, I breathe here, rotate here. She's doing all that hard work, 15 minutes a day in therapy. And then she could live the rest of her life walking leak free until she gets to a point where we could give her a maintenance program, which is a lot less intense than 15 minutes a day. And then, once the symptoms are basically gone, I like to just give a prevention program just to like keep it at bay.
So someone who has like real incontinence, I've heard about like Botox injections. Are those something that is like after you try all these other things, then you might go that direction, or some people just go straight to Botox injections?
It could be. I'm not the best person to ask about this, but I'll give you just my opinion on the intervention side. So from what I understand, Botox is used for a muscle spasm. So yes, if someone is having symptoms because there's a muscle spasm, then as a last resort or something, yeah, that could be something that we talk about. I've seen it be really beneficial, but I don't know about this situation. I've seen it be really beneficial in like vaginismus, painful intercourse, inability to put anything inside the vagina. Sometimes urinary frequency and urgency. It could help, or even bowel incontinence, because there's a spasm and that's preventing incomplete emptying of the bowels. So that is an option. I've also seen patients do the mesh surgery. The efficacy rate is not so good. I think I really can't give you a number. I just don't remember it being significant enough to tell someone to go for it before exhausting PT.
Right. So that's why I would think that you try something lifestyle changes and other things before you do anything under the knife or any even medication.
Yeah, there was a urogynecologist in Brooklyn, which is great. And she sent me a bunch of people, and I don't know why she kept sending me her patients, because they were just canceling their surgeries. They would come to me for like 3 to 4 months. They were like more severe cases. They would come to me for 3 to 4 months and they were like, I don't need, like, I can live with this, I'll do the exercises. I'll commit to it for life. I don't want the surgery. So for some people, if you put the work in, you could do it. Listen, there are indications for surgery. If you have a grade 4 prolapse and your uterus is hanging out of your vagina, then go get a consult for surgery. But there are many cases where it could be avoided.
Okay, so that's a good segue into what is prolapse? How does it happen? What can
So,
you do for it?
so pelvic organ prolapse basically just means that one or more of the organs inside of the pelvic bowl are descending towards or out of the vaginal or anal canal. So that means you could have a bladder prolapse, a uterus prolapse, or even a rectal prolapse. You could also have a vaginal wall prolapse, which means the walls of the vagina are kind of coming in. Most patients would describe the symptoms feeling like heaviness, or like there's a golf ball in their rectum, like something's falling out of their vagina. A lot of patients that have this complain of urinary like leakage, frequency and urgency. And it is treatable. I have a little bit of prolapse. I went to PT for it. I'm doing okay. It's usually caused by constant straining. So like a childbirth that was pretty intense, or if you like push really hard, like chronic constipation, if you're like someone that has hemorrhoids and you're always pushing on the toilet, you're at an increased risk. And then it could also be from like lifting things that are too heavy all the time with like improper form.
So you'll know it. It's not like the bone when your bones get less dense. You don't know that until you know it, or to take a test. Prolapse, you'll know it. You'll feel it.
You'll feel it. Yeah. And if you're not feeling it, then If you're not having any symptoms, then it's okay. Like most women walk around with a grade 1 prolapse and they don't even know. Just after they have a kid, like they have grade 1. It's fine. Like as long as you're not having symptoms, you're okay.
So, if you're not feeling any symptoms, is there a point of checking what's going on with our pelvic floor at this age or at any
So
age?
I'm very much a firm believer in a once a year well check for your pelvic floor. It's always good to just see what's going on because there's always something to work on. It could be something as simple as your coordination, but it just helps prevent things down the road. I always say that I look at our health as a long-term savings account, and everything you put in now, you're going to get out later. So if you don't want to be wearing Depends when you're like, still alive, yeah, go for a checkup. Your therapist could just give you a few things to do at home and start to implement them.
So that who to go to? Is that your only pelvic floor therapist, or is that you can go to your gynecologist and talk to them, or is it
So it depends
regular
where
PT?
it depends what you're looking to get out of it. Technically, I don't know how it works in Israel, but in America, a PT can't formally diagnose you with prolapse. They could just look at it, see what it looks like, treat the symptoms. So it doesn't really matter. Like I kind of practice the same here. It doesn't really matter what the diagnosis is. I'm just treating you, for what's happening. So it depends what you want to get out of the appointment. Like if you want to go the more medicine and intervention route, then you would go to a urogyne, I suppose, unless you could find the urogyne that's a little more holistically minded. And then if you wanted to go the exercise route and the lifestyle changes route, then I would recommend going to pelvic floor physio. I could tell you that in a gynecologist office, most of them will check you for prolapse when you're lying down on your back, which is when you don't feel prolapse symptoms. A pelvic floor physio is trained to check you in a bunch of positions. I've checked patients standing up. I had patients that I needed to check on all fours, kneeling, squatting. Like depending on where you're feeling your symptoms, I'll check, where the prolapse is. We need gravity because gravity's in play when you're feeling your symptoms. So we need to check you against gravity. I haven't had a patient yet that told me they were properly assessed in a gynecologist's office.
Yes, we're looking for a doctor, PT specifically. New topic. Let's talk about vaginal pain, dryness. What can we do for that?
Yeah. So a few things. So I'm sure, as you know, we get dropped off of a hormonal cliff of estrogen when we hit that perimenopausal age. It's funny because it's like kind of the same when you're postpartum and breastfeeding. It's like a very similar
Right.
hormone cliff where you just get dropped off. So our bone density decreases and all these changes start happening and you get the
So
hot
it may be
flashes.
permanent, or they're gonna, it's not like after pregnancy you can get bounced back to regular.
No, it's like after pregnancy, you're going to be menopausal.
Temporarily.
Yeah, temporarily. It's really pseudo-menopausal state. But for vaginal dryness, it's very popular now to use vaginal estrogen cream.
Right.
It's I'm sure you've heard of it.
Right.
It's when you first get it, it's twice a week. You put it on, no, you every day for 2 weeks, and then every day, and then twice a week the rest of your life. That's like the official prescription they've been giving. The studies seem promising. My patients really like it. There hasn't been a study yet that says otherwise. That was actually a good study. So I think it's worth looking into and asking your doctor if it's something that you're comfortable with, putting topical hormones. It goes on the vulva and a little bit inside the vagina. And it really does help with that moistness. Like estrogen is what keeps our tissues like plump and healthy. And it's one of the first things I assess in a patient that's in the menopausal or perimenopausal stage of life. Yeah, so the dryness can actually cause, if you already have symptoms, it could cause things to kind of like creep up a little more. Like it could cause your minor bladder issues to be felt a little more. You might feel your prolapse a little more. If you have, dyspareunia, pelvic pain during intercourse, you might feel that a little more. So while anyone that's not menopausal if they have vaginal dryness, I would say there's a reason why you have dryness. You need to find out why you're not producing enough lubrication. Are you drinking enough water? Are you stressed? Are you being active? Are you doing all the things that would allow your hormones to do that process? You could do everything right in your perimenopausal or menopausal state and still experience the dryness. So that's when I would say to ask your doctor about the creams and use lubrication when indicated.
Right, and it's only localized. It doesn't go through the bloodstream at all.
Yeah, exactly. It's topical. It's not being absorbed
Also helps with
anywhere
libido, they say.
with.
Libido.
Yes, because it's estrogen.
Right. It is a hormone replacement. As far as the studies that I've seen, that it doesn't cause breast cancer or any of those other things that are concerned with HRT, which I don't want to talk about the HRT study in this
Yeah,
conversation. We spoke about
yeah.
another. So that's the vaginal pain. Constipation.
I see a lot of this.
Right.
It's a
So
complex topic.
is that coming from just estrogen, or is that coming just from lifestyle? And what can we do about that?
Everything. Basically, yes, when your body's going through a hormonal shift, you can get constipation. And so when you're in that perimenopausal stage more, that's when we would expect there to either be constipation, or it could even be the opposite, like bowel incontinence, like increased urge to move your bowels, or constipation or incomplete emptying of the bowels, or even changes in how your stool is being formed. The same way we experience constipation in that first trimester when our progesterone levels are rising. It's like a kind of similar situation. And then lifestyle for sure. Like I really do find lifestyle and emotional aspects to be huge in treating constipation. That's why it's really important to find someone with a holistic approach. Constipation can be due to, like you're not drinking enough water and you're not moving enough and you're not eating enough fiber and you're not getting your veggies in. But it could also be due to the actual pelvic floor tightening, meaning there's something called like dyssynergia, where when you go to the bathroom, your pelvic floor muscles, a sphincter, it should open when you're on the toilet. All day, those muscles are on holding in. And then when it's time to go to the bathroom, they should be able to release. Some patients actually have that the opposite. I wouldn't say it's specific to midlife, but it's definitely something to just be aware of. A good rule is that you are the boss of your bladder, right? So as we discussed before, like when you go when you have to go, not just in case, but you go when you have to go, when you want to go, and not the second you get home, because you're the boss. So you are the boss of your bladder, but your bowels are the boss of you. Meaning if your bowels are telling you, you gotta go, you gotta go. Because if you push that off, you're basically sending a message to your brain like, hey, we have more time. And then sometimes that urge actually disappears. And that's something we don't want, because that could actually turn into constipation down the line.
Now, as much as you can, go when you can. Like if you can't, you can't.
Yeah, for bowels, yeah.
Right. Wow. Okay. So we spoke about, you said there were 5 areas of the pelvic floor addresses. Which ones did we not cover yet?
Oh, stability, so core strength.
Okay, let's talk about that.
So as we said, our muscle and bones start to change as we get older. And so I would say that the best way to combat the decrease of strength and stability in your pelvic floor is to stay active. Yes, walking is great. Walking is important. That's the first thing I'll recommend anyone. But if you really want to take your health seriously, and if you really want to stay out of Depends until the end of your life, I really, really strongly recommend resistance training. Anything that's challenging your body, challenging your muscles, challenging your brain's neuromuscular connection to the muscles is going to be huge. There was actually a study very recently that showed that exercise, specifically resistance training, has a similar impact as estrogen on the body. The same effect as estrogen on the body. Exercise,
right,
releases a whole cascade of hormones that's very similar to estrogen. Meaning when you're in a stage of life where you have decreased estrogen, you could basically take an estrogen pill by working out. I could send you the study. It's a very new study.
Yeah.
It's a very new study. I didn't go with a fine-tooth comb yet, but it looks very promising.
Are there specific exercises?
So it was talking about resistance training. So anything where you're lifting weights or using even your own body weight and then some impact as well. So like little hops, jumps, that's gonna help.
How about running?
I didn't see what the study said about running specifically. So I've heard people say I can't run, I have prolapse, I can't run, I have bad knees, I can't run, I have bad back. It's a very high impact sport because you're landing on one foot over and over and over again. Like both feet are the air. It's like you're jumping. I look at running as a repeated series of falls where you're just catching yourself with every step. So it's really high impact. And so if someone has a symptom, they're not going to want to run because it doesn't feel very good. Depending on the severity, you could totally go for a run. You could wear pessary. I recommend going to PT. That's going to help you get to that goal. They'll help you work on your single leg strength, your core stability, your breathing patterns, so that your prolapse is not bothering you during a run. You could wear a support garment when you get out there, as long as it's not the type of prolapse that indicates a surgery. I don't see why not. You just have to work towards it.
Right, so build it up. Like
Yeah.
you're not running a 1 mile even the first day.
No, and again, I'm gonna go back and I'm going to compare this again to my postpartum patients, because they're on the same pseudomenopausal cliff of estrogen. I've had patients that run full marathons, and myself included. My first run back and my patient's first run back is at 12 weeks postpartum, when they were spending the first 12 weeks actually working to get to that point. And that first run is a 10-minute walk, 1 minute run, 1 minute walk, repeated. So 1 minute on, 1 minute off for 20 minutes. So you're really only running for 10 minutes, but broken up. And then you're going to end off with a little bit of a walk. That's how you start. So think about it. If you have prolapse and you're having your symptoms, you want to gradually work your way up to it so that your body has the strength to support and decrease the amount of pressure going down. You kind of like want to contain everything.
So you keep saying the word pessary. So what are we talking about? What is it used for?
So pessary is basically a device. I call it a sports bra for the organs. It goes in vaginally. There are physios as well that are specially trained to fit them because there's many different types and sizes. But it basically goes in and it gives support to whatever organ it is that has prolapse. I think it's mainly used with the bladder and the uterus. And it basically is a sports bra, so it keeps the organ in place so you don't feel your symptom as much. It's not a cure or anything, but it definitely does help.
And you put that in every morning?
So there's different types. There's types that you could just put in like before you play sports or exercise. And then there's types that you could leave in for a little bit longer at a time and then clean it and switch it out and put it back in.
So something you're constantly doing for when you need it. Or for when you
Yeah, there's different personalities. Some people's lifestyles, they really just want set it and forget it and I'll, put it in, take it out in a month. And some people want to have that control over it. If it's like a minor prolapse and they really know they only feel their symptoms when they go to CrossFit, then go ahead.
And I think the fifth one was about blood flow. So are there specific exercises?
Yeah. So it's not really specific exercises. It's really more of the whole system working together. As we get towards that hormonal shift, we'll start to possibly get some like atrophy of the tissue. So really staying active and having what I like to call a well-coordinated pelvic floor is your best bet. Like, remember, we do ankle pumps on the plane, not to get strong calves. We do it to pump blood through the calves. So same thing with your pelvic floor. If it's working optimally, you don't have to sit there and do Kegels. If it's working optimally, that implies that you're doing a lot of the right things by staying active. So it's not a specific exercise that's going to bring blood flow through the pelvic floor. It's that your pelvic floor is part of your core. So it should be turning on and using its ability to distribute blood automatically without you thinking about it.
So we're talking about a lot about different kinds of exercises, more strength than aerobic, what I'm hearing, resistance. Like we're especially at this age, I think at all ages, we're trying to be strong, not thin.
Yes.
I think that's a very important distinction because a lot of times people exercise to look good, but I think that if we're in our mind, we're looking to strengthen rather than just only to look good, then I think we'll look good when we look healthy.
Yeah.
But also, like you said, I like your metaphor about the savings account for the rest of your life. It's like you'll really appreciate it later that you have put in the effort now.
Yeah, for sure. And I just want to touch on what you said about feeling strong and not looking good. My big
Also
thing,
looking
because
good.
yeah, I mean, that's important too. But my really big thing that I stress with my patients is like, let's say I have a patient who has weak glutes, right? And they have a flat butt. Okay, they have a flat butt and they're like definitely self-conscious about it. They verbalize it to me. And then I give them all these glute exercises for their back pain. And they're like, oh, is this going to give me a big butt? Because I really want a big butt. And I tell them, listen, our goal right now is for your brain and your muscles to be on the same page. Will your glute muscles hypertrophy and look like a rapper? I don't know. I don't know. It depends. There's a lot of other factors to it. But at the end of the day, I think if you set a fitness goal for yourself, like, hey, I want to have strong glutes so that I could lift my kids and do my grocery shopping and go hiking and feel really good after. When you're done
Or
working
lift your
towards that
grandkids. We're
goal,
talking up to midlife.
yeah, for sure. Yeah. Once you've reached that goal of being able to do that, you're probably going to like the way you look and feel really good about yourself. Not only because you physically changed, but because you're proud of yourself, you've achieved something. You're going to respect yourself more.
That's so important, is actually feeling good in your body, but it's a strong body that's going to hold you for the rest of your life. And today we're living for much longer than the past. So we're living 70, 80, 90. So we really have to do what we can, especially now when you're younger, when we can build that strength and build new habits and whatever's left of our estrogen to actually build up those bones and muscle, to actually start doing this as early as possible. I would say, I think we should be doing this from preschool all the way through life, but
Mm-hmm.
today's the second best day to start.
Today's the second best day. Yeah.
So if someone wanted to reach out to a doctor or a healthcare professional, besides a pelvic floor therapist, what other people deal with this part of the body?
So there's
Depending, of course, what the symptoms are.
gynecologists. Yeah, there's gynecologists and urogynecologists. I've heard of some OTs, occupational therapists, actually now specializing in pelvic floor health. I think it's really interesting because they have a different approach, but they treat the same diagnoses. So that would actually be a really cool experience. They take the same courses as us, but they're coming at it from a different background. And there's also nurse practitioners now that are specializing in pelvic floor health.
So this is anything else, any final words that we should be thinking about as we really, because this is a whole area that at least during our pregnancies, those of us who gave birth years ago, pelvic floor was only about Kegels. So there's so much more it's like opened up so much more to think about. So
Yeah, I think my number one advice for anyone that's in this stage of life and wants to take charge of their health is to form the healthy habits now. Pick one. So like listen to the podcast, think about, one of the tips we said, whether you want to nurse your water a little bit slower throughout the day, you want to get more steps in, try some resistance training instead of just doing your aerobic, like just pick one and focus on that. And then once you feel comfortable, I would, just keep slowly adding them in. And another important thing is like now it's your responsibility to pass this on to your kids and set a good example for them. Normalize taking charge of your pelvic health. I think we're so trained to be ashamed and embarrassed of this, but it's literally a part of life. And if a man had any of these issues, they would be in the doctor 1, 2, 3.
or not.
So
Some men don't go to the doctor.
yeah.
Yes, women definitely should be taking care of ourselves. I think with the lessening of estrogen, our changes happen much quicker than men.
Yes, they do. They do.
And
And
then women are more, bottom line is if we don't have a good core and we don't take care of our bone health, then it hits women much harder than men.
yeah, and it doesn't have to stink. Like menopause doesn't have to stink. There are like so many foundational things you could do in the years leading up to it. Basically everything that we mentioned today and more, but a lot of good points were made here today to mitigate the roughness of how it could come on.
We said so much. I think that people can listen to this a second time. That's the beauty of podcasts. Um,
Yeah.
Millie, how can people reach you? And do you have any resources on your website or Instagram? I know your Instagram is full of important information, your stories, your posts. So how can people reach you?
Yes. So you can, first of all, find me on Instagram. It's at Millie DPT, Millie. If you reach out to me there, I will put you on my newsletter and you'll get some really cool weekly emails. And I give out these PDF guides. So I always pick a different topic. Sometimes it's about bladder health, sometimes it's about bowel health, sexual health. So those have been really popular. And you could also find me on email, which is milliedpt@gmail.com. My website is under construction.
Okay, well, you'll get there. All right, and so you do some telehealth as possible because right now you said you're in
Yes.
Israel, but
Yes, you could send me an email at milliedpt@gmail.com and I could send you a link to book there.
all right. So thank you so much, Millie. This is so much information and so important. All right.
Thanks for having me. It was great.
Thank you for joining me in another fascinating conversation about midlife. If you'd like to reach me, Devora Krasnianski, to talk about your midlife or anything else, you can reach me at jewishmidlife@gmail.com. You can also find us on our website, jewishmidlife.com, and follow us on Jewish Midlife on Instagram or Facebook, and join our conversations in our Facebook group at facebook.com/groups/Jewish Women Talk About Midlife. And share what we're doing with your friends and others in the midlife phase.